Right. Good afternoon, everybody. Now, we are using toric lenses all the way. If nowadays, if the astigmatism is more than, let's say, 1, I go for toric lenses. But many times, when the toricity is not very high, if the patient, if you're going for a simple monofocal lenses, then there is some amount of residual toric. What do you do? And even if you are going for toric lenses, there's some amount of residual toricity is there. What do you do? Then probably the answer is LRI or Arcuate incision. But if the patient cannot afford the FLACS for Arcuate, I have a little bit of innovation on this, that if you have a Varion, and if you do not want to spend money on FLACS, you can do an Arcuate incision by the help of a dental keratomy knife, Arcuate knife. So that is the idea. It is a very safe surgery, and the main indication remains the residual corneal astigmatism at the time of the surgery and the residual astigmatism after the toric lenses. If you go more towards the center, more is the irregular astigmatism created by the Arcuate incision. But if you go LRI, it gives you less impact, less effect. The femtoseconds are, since it's done by the laser, it is reproducible. And you never perforate that. The LRIs, they are never all that consistent. Technically, the femtoseconds, they are not LRIs, they are Arcuate incision. And it creates the intrastomal ablations. So you have to, further make the incision full. You have to create the incision, you have to make the incision, you have to go full thickness. Like if you give a corneal incision, it will not go through and through. You have to use the spatula and make the incision. So these are the preoperative requirement of the instruments. There are certain nomograms if you're going for manual, and for Varian you have got in the Varian you have got the planner to go for a Arcuate incision. And basically you go for the axis. What are the axis? What is the arc size? What is the depth? How deep you have to go? And what is the optical zone? They all determine the amount of astigmatism being corrected. So on your left hand side, the Varian gives a picture. So you can go for a toric IOL. On the right hand side, there's small amount of astigmatism that can be corrected by Arcuate incision. It gives you that incision should be at 155 degree. It gives you that the Arcuate incision should be approximately 19 degree arc, and the depth is set should be 85%. I do a modification here. I go up to 95% depth because I had been an arc surgeon earlier, so 85% depth doesn't serve you much. So this is the arc knife, and dramatically on the left hand side you see when you go for a incision, they tell you the degrees. And in the lower one, you see the rhexis marks. So with the help of these two, you can use your Arcuate knife and do the surgery and have the astigmatism corrected. We have done the studies. So let us not go into the detail all the statistics, but it told us in our 113 cases that the Arcuate incision manual done is much better, whatever way you see, whether it's a photopic conditions or a mesopic conditions or a 7-day post-op or almost same, but after 7 days, in 90 days and onwards, it is much better. So the image guided system can plan, that is very own, no financial interest. The image guided can execute, but the corneal thickness measurement by the pachymetry or any other machine like OCT cornea, pentacam, and the Arcuate diamond knife can help you to achieve. This small video, so you can see the degrees and it has already told me what is the arc. You see, the FLACS has made the incision, but you have to complete the incision, you know. You have to go deep, probably multiple times. It was a small, now this is even the bigger one. You have to really work hard. You go deep, and you have to see to it that you have made the Arcuate incision proper in proper depth. So you have to be well experienced, and even if you are experienced, it is not necessary that you complete the Arcuate incision properly. So it is one of the reasons that the manual incision is better than all these FLACS. In manual incision, now first of all we are marking the arc from where to where, from this degree to this degree, and on the other hand, on the other side also, beyond 30 degrees. Yeah, then you take a diamond knife, measure it, and the intended height it has to be approximately 95%. And you see the rexus marking. So you have to make the arc around this rexus margin. You have to give pressure, you have to hold it properly, you have to be consistent, you have to be very, very stable. Such a nice arc. And the same thing has to be repeated the other side. And these Arcuate incisions are supposed to be made before we start the cataract surgery. There is a small clipping again, and that's the end. So I am marking the arc from what place to what place. Planned and shown in the very on. So this time we have to do the Arcuate incision at 8 millimeters optical zone. So this 8 millimeter optical zone will be shown by the very on. Now the stitching starts. Can't afford to slip. You have to hold the pinion cover almost exactly as the limbus. And you complete the incision. Thank you very much. I do not prefer the Arcuate incision because, you know, it makes your cornea useless, and you cannot do cornea grafting in such cases. But then what can you do? If the patient wants a very good vision and you are putting a toric lenses, even then some kind of a residual thing is there, and putting the patient into the FLACS, you have to spend a lot of money. Even the one PI costs around about 25,000 rupees. So I think this is the best way. Thank you, sir.
Thank you so much, Dr. Kashyap. I think in today's time, the toric correction is must. Let it be monofocal plus, EDOF, trifocals. Toric has to be corrected to a minimum possible post-op refraction. Otherwise, all your calculation for a patient's outcome can be totally challenging in the post-op period. And nothing better than toric IOLs in terms of correcting the corneal astigmatism with cataract surgery. But if you can correct with various other ways, what Dr. Kashyap very nicely depicted, I think we should thank the radial keratotomy surgeries in our time, where we could have these calibrated diamond knives, which can give you the exact depth in microns and achieve the depth and the cut, which is so clean, sharp, like a lasers only. And I'm seeing young people sitting here, they would have not seen these knives. In our time, they were must for our anti-segment refractive surgeons. And that can be used for making arcuate incisions in the cornea and achieve the reduction in the corneal astigmatism. And titration, calibration, nomograms should be known for before you do all these cases.